Greetings and welcome. My name is Brad Monk from Phoenix, Arizona, and welcome to the GOG Partners Highlight Reel. We're here with 4 senior members of the GOG Partners organization to contextualize and discuss recent presentations at the ASCO 2021 meeting. So honored to have with me Katie Moore from University of Oklahoma. Katie, welcome.
Thank you so much for having me.
Leslie Randall from Richmond, Virginia.
Hi, great to be here.
And Tom Herzog from the University of Cincinnati. Welcome.
Great to join you, Brad, and all my colleagues. And I'm tired of hearing the word senior. Stop using that.
Thanks, my friends. Well, so let's get into it. I think the biggest and greatest opportunity to impact ovarian cancer is in the beginning. And as you recall, in June of 2018, a GOG-218 got approved. Frontline bevacizumab with carboplatin and paclitaxel continued in maintenance for a total of 15 months. Now, Tom, we never really defined the duration of bevacizumab, but that was addressed in a randomized phase 3 trial here at ASCO. Tell us about that study and what your take on that is.
Yeah, sure, Brad. So that was known as the BOOST trial, and the full-out name on its optimal treatment duration of bevacizumab combined with carboplatin and paclitaxel in upfront ovarian cancer treatment. It had a lot of numbers. It was basically an NGOT, AGO, and others trial. Lead author that presented was Dr. Pfister. It was a large trial, Brad. I think what they really built this off of was sort of the hypothesis that if you looked at the PFS curves from ICON 7 as well as, and maybe more importantly, GOG-218, you saw a diminution in the effect at the time that the Bev was stopped. And that was the hypothesis behind this study, was that had the bevacizumab had been continued in the treatment arm for a longer period of time, you wouldn't have seen the event rate become the same in both the arms, which is what you quickly saw. And so the question was, would prolonged treatment really help at all? And I think that, it's certainly a very, very important question that was asked. It's a very large trial. There were 927 patients enrolled in the trial. It's randomized phase 3. And basically, they took patients that had stage 3B and 4 and randomized them to standard treatment, which would be the 218 treatment, not the ICON 7, which was a lower dose and a shorter period of time of only 12 months, but rather 15 months of Bev maintenance at 15 milligrams per kilogram versus doing that for 30. So they had one arm called Bev 15 and one arm called Bev 30, which is not referring to dose, but the duration of the number of months that they treated these patients. So really just then the primary endpoint was investigator assessed progression-free survival. And they randomized over 460 patients in each arm. They had pretty good balance between the two groups, as you might imagine, with a large study like this. So there really wasn't anything. The only thing I noted that was interesting is they had no information on BRCA status, which, as we know, can play a major role. But everything else was very well balanced. Interestingly, they had a look at the relative dose intensity, which could be an issue as well. Were you able to achieve what you set out to do? In other words, give more Bev, and in fact, they were able to do that. So it was feasible to give Bev for a longer period of time. And you didn't see a big drop off in the expected relative dose intensity. So it's about the same in both arms in terms of what you were trying to achieve. Adverse events, really interesting there in that you saw a little bit higher in the rate of adverse events in the group that had double the treatment time of 30 months versus 15 months. But it really wasn't all that appreciable. It was by a small amount. And so that was interesting. It sort of speaks to the fact that most people that are going to be intolerant of Bev, we find that out early in their treatment course. And indeed, that's not a problem later on, and people make adjustments and so forth and learn how to use it. Hypertension, for example, was 20%, and this is a grade 3 or greater, 20% in 15 months versus 25%. That was one of the larger differences. Everything else, like even Press syndrome and some of the any grade 5 was actually higher in the shorter treatment groups, which tells you that there's just no relationship. Once the patient's on Bev and can tolerate it for 15 months, they probably can tolerate it for 30 months. Unfortunately, though, let's get back to the main point of this study. That was to show a difference in progression-free survival, and there really was no difference. It was 24.2 months in the 15-month group cohort and 26 months in the 30-month cohort. So the hazard ratio on that was 0.99. They noticed that the distribution was because of the it wasn't normally distributed, the data, so they did a restricted means analysis. It also showed no difference, 0.92. They interestingly looked at earlier stage, sort of the breakout of the old ICON 7 data, the high risk versus low risk. They saw really no differences there either. So everything they looked at really didn't show any significant difference. Overall survival was 1.04 on the hazard ratio, so no difference there as well. So they concluded that it was feasible, which is true. But unfortunately, it didn't really show any advantage. So I think for me, this was a little bit disappointing in that I was hopeful that we would see a little bit more of an advantage. Things to think about in terms of the trial design, they probably under calculated for how the control arm would do. The control arm outperformed what they used as the historical control, which we often see as we get better and better with giving these drugs and so forth, and surgery gets better, and we just always seem to use these historical control arms at our peril, and that's indeed what happened here, and so they ended up being fairly equal. So I thought it was a good trial. It was an important trial for people to understand. I think some people have already started had started doing a longer use of Bev, and I don't know if anybody on the panel has, but I know people that have. I have on occasion where we're trying to be super aggressive. So good to know. Does this apply to every individual? I don't know, but there's certainly no data to support going beyond the 15 months at this point.
Yeah, Tom, that was excellent and succinct. 262, the weekly versus every 3-week paclitaxel study, John Chan, New England Journal, treated until progression. And so the intention here was sort of to overcome the banana curve that we talk about. Were you surprised, Leslie, at this result, or is this what you would have expected?
It's interesting to ask me if I was surprised. I think I didn't really have an opinion. I was just curious to see what the result would be. And, more is not always better, obviously, except for Katie Moore. She's always better. But, but more Bev is not better. And I think it's great to know this. I think it's great to have this information because we're all tempted to do these, like Tom said, in certain situations. We want to be aggressive.
One of the things that you've taught me, Katie, is the duration maybe isn't as important as getting the right medication. So who is the right patient for bevacizumab today, do you think?
I think yet to be seen, as our good friend, Dr. Aegis Alvarez-Secord is always reminding us, we don't have a biomarker. And so really we're kind of using a surrogate biomarker of those who aren't going to respond as well to PARP, which is homologous recombination proficient. And I would also say those patients who have higher risk clinical features, although bevacizumab works in all patients, as we well know, but those with ascites, those with really bulky disease that you need to get under control relatively quickly, in my mind, are the patients that I'd be thinking about bevacizumab so I can get them responding quicker and feeling better. And then the maintenance, do you add Bev or not, I think really is a molecularly driven decision at this point.
Yeah, I like what you say, but they're not connected. You decide to use Bev, yes, no, and then if you're on Bev and HRD, you add PARP, and if you're not, then you can add PARP alone, or if they're HRP, you can continue the Bev. So that's interesting.
Yeah.
So almost all these patients still recur, Tom. I thought that was a take-home point. And so and almost all of these patients have platinum-sensitive relapse. So we'll talk about that in the next segment, but I want to talk about a couple other papers, Katie Moore, that you're very passionate about, and you lead the USPI for FIRST, and you did Imagine 50. we want to get IO frontline. Tell us about that, checkpoint inhibitors or other IO medications used in the frontline opportunity.
Yeah, I am passionate about this. Thank you. I think we all are. We've just heard about the kind of extension of the bevacizumab story, and I think we're kind of clear on how to use that now, a decade after the studies were run. And we all know, and we'll talk about a little bit more about the impact and the role of PARP inhibitors for all, but certainly in molecular subgroups, there's just a tremendous benefit and hopefully cure. But as you just alluded to, the majority of our patients are still going to recur. So how can we continue to modify the front line to prevent that? And we have done 2 big studies, 2,300 patients actually, that have resulted incorporating an immune checkpoint inhibitor, one avelumab and one atezolizumab, in different studies, but similar enough just to say about both of them that they both were negative. And so one negative in the wrong way, suggestion of harm, and one just entirely negative with no clear subgroups that really kind of spoke to benefit, inclusive of homologous recombination deficient or BRCA, where I think we all thought for a long time that those would be the women or tumors that would respond best to immune checkpoint inhibitors. And the preclinical for that was beautiful, but it did not pan out. And so I think there's a lot still to learn. We have 4 studies that are completed and maturing that include immune checkpoint inhibitors with or without PARP inhibitors and with or without bevacizumab. And so the next few years is going to be interesting to see if any of those have different results with the addition of PARP to what has been presented already. But really, I think it's time to kind of not move on, but move on to some different aspects of immune oncology, and see if we can approach ovarian cancers differently. Because I think as we understand better now, immune checkpoint inhibitors don't activate the immune system. They unmask a tumor from an already activated immune system. And ovarian cancers in large part don't activate the immune system. So what can we do to do so? And so there were kind of two studies. I'm going to talk about 2 studies that were presented. The first is sort of I'm going to mention because it was nicely done, is Isabelle Ray-Coukard presented what's called the NEO-Pembro study, which is kind of a riff on Imagine 50, except with pembrolizumab and only in patients with neoadjuvant chemotherapy. And the endpoint here was looking at complete operative resection at the time of interval surgery. So that was their primary endpoint, randomized phase 2. And the bottom line is there was no difference in achieving a complete resection at interval cytoreduction with the inclusion of pembrolizumab. And then they looked at progression-free survival, which was similarly the same. And so really very consistent with the lack of benefit seen in Javelin 100 and Imagine 50. So I think we have to put a fork in the idea of just adding an immune checkpoint inhibitor to chemo and to follow. But the other study that was presented, again, it's a subset analysis, but it is interesting, is a subset analysis of the VITAL study. This was presented by Rod Racconi. And just to remind folks kind of what we're talking about, this Vigil vaccine is a novel autologous tumor cell vaccine. And basically, you do a biopsy, they manufacture this autologous tumor vaccine that is meant to increase neoantigen expression via MHC class 2. And so that increases dendritic processing and hopefully leads to this systemic immune response. And I think as we all know and have heard, the all-comer study was negative. But then they parsed it out by homologous recombination proficiency or deficiency by a different method than every other PARP study. So please keep that in mind. But they did identify a group of patients as homologous recombination proficient and presented them here. Subset analysis. And what they demonstrated was a difference in progression-free survival that basically doubled with use of the vaccine as a maintenance therapy, 5.7 to 10.6 months with a hazard ratio of 0.38. And an overall survival was similarly impacted with a hazard ratio of 0.41. And so our good friend Rob Coleman always reminds us that placing a lot of decisions on a subset analysis can be somewhat foolhardy. So this definitely requires validation in a larger study, but that's a pretty big signal to ignore. You know, a hazard ratio of 0.4, 0.3 is on par with what we see with PARP and BRCA associated cancers. And so, you know, if it's even double that in HRP, it's still better than anything else we're using. So I think definitely worth exploring, as are many other kind of adoptive T-cell transfer sorts of therapies that are under development right now. But this is sort of one of the first signals that maybe this will be effective. So exciting.
Yeah, so stay tuned, right? You know, we
Stay tuned.
represent the GOG partners, and you know, there's a number of trials with this exciting agent in development, and I'm particularly excited about this HRP frontline, helping identify opportunities where they really are limited. And I want to thank you, Katie. You're very humble, but you know, you chair the NRG Ovarian Cancer Committee, and you're one of the associate directors for GOG Partners. So I want to thank you for your selfless sacrifice and for all the wonderful things that you're doing. And I hope to have some other big wins like Solo One was in the very near future. So
Me too.
for
Me
patients,
too.
for sure. So Leslie, you've been a big advocate of biomarkers. You know, Katie says, look, we don't have one for bevacizumab, but we do have them for PARP. And I'm just going to keep rolling here. You know, most patients recur. There was some papers about platinum sensitive relapse and biomarkers and PARP inhibitors, particularly the exceptional responders in Aerial 3. Tell us about that. And there's also some niraparib data that was summarized. Excited to hear what you have to say.
Yeah, thanks, Brad. You know, these types of papers are exploratory, obviously, and not definitive, but I think this is all the data that we sort of crave, like this drill down, right? So Aerial 3, everyone probably remembers, was a phase 3 trial of rucaparib maintenance in the platinum sensitive recurrent space, and showed a significant benefit of rucaparib consistent with all the other PARP trials in that setting. And in this study, they looked at both an exceptional responder population that had a PFS greater than or equal to 2 years. And they also looked at the early progressors. So those patients who came off for progression at the first scan, which is about 12 weeks after completing their second line or third line chemotherapy. And what they found was that about 21% of the rucaparib treated patients were exceptional responders. And interestingly, 2% of patients in the placebo group, so had some inherent, you know, disease biology that gave them that long progression-free survival, but clearly a bent towards the rucaparib being better, as was shown in the trial. So the clinical features that were associated with exceptional responders were having had a complete response to that chemotherapy, or no measurable disease at the start of treatment, which sounds like the same thing, but it was a little bit different in the trial. And then the last platinum-free interval being greater than 12 months. So if they had that long second or third platinum-free interval, was predictive of exceptional response. Now they would looked at the molecular, which is what this is really about. They found that any mutation, so BRCA1 and 2, RAD51CD, ATM, ATR, Fanconi anemia pathway, any of those mutations, there were some exceptional responders, very enriched for BRCA, and because those are the most common mutations. And then, but you know, there was some overlap with the early progressors. So we had BRCA mutated patients in the early progression. There were no RAD51C or D. And, you know, that's pretty consistent with what Liz Swisher has shown in the past, of how exceptionally responsive RAD51 patients are to PARP. It's hard to show really definitive answers in that population because it's really just so small. But very consistently showing that, you know, those patients have exceptionally good outcomes. Interestingly, BRCA2 confers a better response to PARP and prognosis than BRCA1. So we've been starting to see that. So this is more data to corroborate that. Interestingly, in this population, there were 14 cases of MDS AML. So for a toxicity perspective, 9 of those cases were in exceptional responders. So you can, you know, you could think about this in many different ways, right? Was it a mutation? Was it platinum exposure? Was it the PARP exposure? Who knows? They didn't drill down that far, but they did report that 9 of the 14 cases were in that population, which is interesting. So that was that abstract. The second abstract we want to talk about today is a culmination of the niraparib trials. So we now have 3 phase 3 trials of niraparib and frontline Prima, and then in the second line, both Nova and Nora. And looking at this abstract, looked at just the germline BRCA mutated subgroups and looked at their outcomes. And it basically was a reiteration of what we had previously seen. Just, very excellent responses, very significant hazard ratios in this group, ranging from 0.12 in Nova and to 0.4 in Prima. So not to cross-trial compare them, but just to, lump them together, look at this data collectively, and again, show that BRCA mutated patients have exceptional responses, not defined in the first abstract, but have exceptionally good outcomes when given PARP inhibitors in the maintenance phase. And no new safety signals were seen in that abstract.
You were talking to me the other day and you said, "Oh, I got goosebumps. I just got goosebumps." And so I'm holding up the mirror and reflecting what you said, because biomarkers enrich clinical benefit. And so we should get goosebumps when—
I'm glad you said that, because I'm studying them, reading this and looking at these abstracts. I'm like, God, we look at a hazard ratio of 0.3 and I'm like, it's normal. That's not normal. Like, that's exceptional. That's highly significant. And I think we can't take that for granted, even though we keep seeing that over and over with our PARP inhibitors.
And so, Dr. Go ahead.
If I could just say one thing, to have a 10-fold increase,
I know, right?
10-fold increase in being an exceptional responder from 21.1 to 0.1%.
Thank you for adding that. I was going to say, Leslie, Dr. Randall chairs our cervical cancer portfolio within GOG Partners. But as you can see, she's really smart in ovarian cancer too. So I'm glad that you were able to share that with us. Now, Tom is also the Associate Director of GOG Partners. Dr. Herzog has been a big advocate of randomized trials, right? So randomized trials, we talk about PARP. Aerial 4, I think, is one of the most really definitive studies ever, Tom, that show that PARP inhibitors are not only good, but they're better than what we used to do chemotherapy. Tell us about that.
Yeah, who would have thought, right? If you'd have thought about this, 10 years ago, when some of the companies were not even interested in developing their own PARPs, and some of the things we saw,
yeah, right.
Even though we saw some strong signals, but no one had put the light on them in the way they needed to be put on them. And then to think that you could substitute PARP for chemotherapy, which was done in Aerial 4, as Brad alluded to. And what they did at the recent meeting at ASCO was look at the subgroup analysis from this. This was Amit Oza looked at this from those. Of course, all these patients were BRCA mutated, which you would expect them to have better responses to PARP in the first place. But these were all relapsed ovarian cancer. They looked at the effect of platinum sensitivity in this phase 3 trial to sort of break that down and see what the difference was. So within the trial, they took patients that were at least a month out. They called them platinum resistant up to 6 months, and then those that were partially sensitive versus those that were considered to be fully sensitive. And then the way that study was designed is you received either weekly paclitaxel if you were in the resistant or partially sensitive cohorts, and then you received platinum-based chemotherapy, which would be a doublet, if you were fully sensitive, versus rucaparib. And so that's how the randomization occurred. And what they saw is, when you break it down that way, that the hazard ratio in terms of the greatest benefit was clearly in that partially platinum sensitive subgroup, going up against the weekly paclitaxel. You still saw a benefit, but not statistically significant in the fully platinum sensitive subgroup. So when you went up against both, you didn't win. And same in platinum resistant. The hazard ratio favored rucaparib, but it was not statistically significant when you break that down. So, it's very interesting, I thought, and looking at that the safety and so forth was pretty similar to what we've seen. The rucaparib treated patients had comparable or longer PFS in all the cohorts that were platinum sensitive. So that was interesting. Safety profiles were the same, and this really suggests that it's an effective treatment for those that are heavily pretreated, regardless of sensitivity to platinum. And so I think this just gives you another nail in the toolbox, if you will, that you can use for patients that you may want to avoid chemotherapy in. So I thought it was a good trial. Obviously, subject to all the problems with subset analyses and so forth, but I thought it was a good trial.
Another thing, Tom, I just wanted to thank you one last time is, although you're associate director at GOG Partners, you're actually the treasurer. There was a paper published on our structure that all of us are co-authors on in gynecologic oncology. It can be downloaded for free. But GOG Partners tries to, pay our sites for their hard work, right, and at a fair market value. And that sort of vision and operational aspect is you, Tom, and I want to thank you. Working for free, I think, is important, but it's not sustainable. So I think Dr. Copeland's motto is fair and accountable, and you sort of make that happen.
I think we continue to evolve, and folks you're seeing on this screen, and the others behind us, and the great team we have behind us, behind them even, is really, I think, we've had a retreat. I think we've gone back to looking at our mission statement, and we've really made some changes, and we'll continue to make those changes to make sure that the monetization of this backs our principles and backs our main mission, which is to help women who have these cancers. And I think that if we're smart about it, we're going to be able to do this in a really elegant way that is really going to make a difference.
Thank you. And Katie, I just want one comment and then we'll move on. So the hazard ratio, if I'm not mistaken, for SOLO2 is 0.30. So platinum sensitive maintenance, and Tom just talked about another trial, and Leslie. The hazard ratio is also 0.3, I think, for SOLO1. So it doesn't really matter when you use a PARP inhibitor, right? You can either use it frontline or second line. I mean, there's no reason to use it frontline, right? Preferentially.
That makes my head explode.
Oh,
No. So, but I think a lot of people think that. So you cannot compare hazard ratios across trials. The hazard ratio is a reflection in the reduction of risk of an experimental arm to a control arm in that particular study and in that particular population. And so a hazard ratio of 0.3 in SOLO1 and SOLO2 is incredible. It's unprecedented, a 70% reduction in the risk of progression in each of those settings. But it doesn't mean the magnitude of benefit is equivalent, because it's based on the expectations of your control group. So in SOLO2, we all can reflect on the control group, which is 5.2 months in a BRCA-associated platinum-sensitive population. And so a 70% improvement on that is fantastic, but it's not hard to improve upon 5.2 months. That stinks. And the front line, it's almost 14 months. And so a 70% improvement on 14 months is a much bigger lift for a drug. And so the magnitude of benefit is not just 70% and 70%, it's relative to where you start, which is your control arm. So that's point one. You cannot compare hazard ratios. You can't even compare PAOLA-1 to SOLO-1. You can't compare the hazard ratios. And then point two is that we'll see. I don't know anything in insider information, but I believe we've cured more women with SOLO-1.
Agreed.
And at 5 years, we have 50% of women randomized to olaparib disease-free versus 21% in the control arm. It almost feels unethical that we had a control arm at this point. And so, we'll have to see. We're only 5 years. We're 6 years. We haven't looked at the data this year.
Yeah.
And you really need to be 7 to 10 out to call OS. So we have some time, but I believe we've cured more women, and you can't cure people in the second line.
Brilliant. So these patients now, they're getting PARP inhibitors frontline, and thank you for that. Very, very good explanation. I was hoping you'd say something as impassionate as you did. But patients become PARP resistant sometimes. There were 2 papers that looked at that. Tell us about just sort of what the idea was. And so when these sort of overcoming PARP resistant studies enter randomized registration trials, that they'll be familiar with the concept. Go ahead.
Right. I mean, this is anyone who's listening to this is already seeing these women in your clinic. We're already seeing them. This is not a future problem. This is a problem now. And we're not quite where we need to be in terms of knowledge. So we do have an increasing understanding of mechanisms of resistance for PARP inhibitors, both in BRCA wild type and in BRCA associated cancers, reversion mutations being important. And we even understand more about the different types of reversion mutations now. It's not just a reversion mutation. There's a whole bunch of them, and we may be able to target them. But right now we're focused on overcoming PARP resistance. And the first lob at that and great study was done by Stephanie LaRue called the EVOLVE study. It's published in Lancet. You should look at it, where she took women whose tumors had progressed on PARP and biopsied them, and then gave them olaparib cediranib in a number of settings, and basically showed an amazing amount of translational research as to what happens in the setting of PARP resistance, upregulation of CCNE1, and that will be important when I talk about these two studies. You acquire CCNE1 amplification in a BRCA-associated cancer. Those should be mutually exclusive, but it's acquired, and that's a mechanism. A whole bunch of other things that could not be overcome with olaparib cediranib. So that's kind of off the table. And so what we're looking at now, and these two studies at ASCO were great, and I think are the road to the future, although not entirely there. The biggest one was done by Shannon Weston, our good friend. And this takes olaparib and the WEE1 kinase inhibitor adavosertib, of which we all know and love and want AstraZeneca desperately to develop. Small plug. It's a WEE1 kinase inhibitor. So when you remember back to your cell cycle, there's checkpoint 1 and checkpoint 2. When you lose TP53, which is ubiquitous loss in serous cancer, you rely on the G1S checkpoint, or the G2M checkpoint, excuse me. And that reliance increases your replication stress and dependence on that checkpoint. And so importantly, even in someone with a BRCA-associated cancer who has PARP resistance because they're of restoration of homologous recombination proficiency, that BRCA mutation still plays an important part in replication fork stabilization. And so targeting replication stress is still a very evidence-driven intervention for these patients. And so it's based on that. So this study is the EFFORT study, and it took patients, it was 114 enrolled, 80 treated, PARP resistant, all of them. And half of them got WEE1 alone, adavosertib, and half of them got adavosertib with olaparib with a novel dosing. It was daily dosing instead of the BID for 5 days in a row, week 1 and 2, and then week 3 off, and then continuous olaparib. And about a third of the patients were PARP resistant, but still platinum sensitive, and the rest were platinum resistant. The prior PARP indication was about 50-50 treatment and maintenance, which may be important as we start to develop these trials. And so when you look at the clinical activity in the whole group, it was kind of like a little signal. Response rate was 23% in the monotherapy adavosertib and 29% in the combo, and that's pretty respectable. But when you look at, you break out the BRCA mutated versus not. In the mutated cancers, surprising to me, the response rates were 20 and 19% respectively. So not a great signal there. But in the PARP resistant BRCA wild type, single agent adavosertib had a response rate of 31%. We've never seen that with single agent adavo. So that's pretty striking. And then the combo was 39%. So very high. Now there were problems. This isn't like a friendly regimen. So you had drug discontinuation in only 5%, which is pretty respectable, but reductions in about half and interruptions in about 2/3 for monotherapy adavo. And then when you looked at the combination, you had about 10% of patients come off for toxicity, and then dose reductions in 56%. So I think we still have some work to do with the tox, but this is a nice signal of efficacy for this combination. Now, a little bit earlier than this, but equally as exciting, was work presented by, it's really out of Dr. Fiona Simpkins' lab, and presented by her collaborator, Stephanie Wethington, again, looking at olaparib and trying to target that replication stress, but coming at it not with WEE1 inhibition, but ATR inhibition. So this combined it with ceralasertib, it's hard to say, ATR inhibitor. And this was a phase 1 tons of preclinical data from Dr. Simpkins, who is brilliant and has done a lot of work with ATR inhibitors, but really they enrolled 13 patients in this phase 1 and had an overall response rate of 46% with a PFS, which is hard to really put numbers around in such a small study, but it was 7.5 months. And all of these patients, importantly, were PARP resistant. So small study, are some safety issues, but a little bit less than with olaparib. So I think this is quite promising and really, again, shameless plug, really deserves a bigger study to validate it in this
Exactly.
population so that we can figure out how to use it. So these are exactly this, and Shannon's, Dr. Wesson's study has translational work, TBD, as will this work. So these are the future. These are the studies that are going to drive what we do next, and I'm really proud of the researchers who put them together.
So time is running short. I want to talk about 3 additional very brief points. And one, Tom, I know you're also looking at some doublets and triplets that were addressed here in ASCO. Tell us about briefly those doublet and triplets that you're excited about moving forward. Excellent job, by the way.
I think, you know, one of the ones that was presented by, you know, a good friend of ours who's in the pack, Dave O'Malley, was the lead author who directs our ovarian portfolio for GOG Partners, presented on mirvetuximab in combination with Bev. And for those of you that don't know, mirvetuximab is an antibody drug conjugate that targets folate receptor alpha, which is overexpressed in about 80% of women with epithelial ovarian cancer, and has a potent tubulin cytotoxic that's attached to it. So this is the final results of this particular trial, and it was, you know, it was mainly to look at the anti-tumor effect. And as I understand it, I think they excluded low. Katie, you've been involved with this program for a long time on
Yep.
Forward One and so forth, but they had medium and high folate receptor expression patients that were included. And the high was 55%, and the remainder, 45%, were medium. Platinum-free interval on this, so it was a mix. It was agnostic as to the platinum sensitivity, if you will. So 53% of these patients were platinum resistant, and then 33% were between 6 and 12 months. And then the remainder, 13%, were greater than 12 months, so highly platinum sensitive. I thought that the overall cohort just had some pretty astounding numbers. Now you have to I guess, protect against over enthusiasm. What did you have, Leslie, the other day? You had what? You broke out in hives or?
Goosebumps.
No,
Goosebumps.
goosebumps.
Not hives.
Not a
Hives.
true anaphylactic reaction. I got it.
Hives are negative.
So, you know, these are pretty exciting numbers in terms of response rates, but you sort of have to temper that with the fact that it's only 60 patients. You get into small subgroups and everything else. But this was, again, in combination with bevacizumab. The overall cohort was 47% response rate.
Wow.
But then when you start breaking that down, women with folate receptor high expression, 64%. And those that had high expression in platinum resistant ovarian cancer, the response rate was 59%. It's almost 60%, which, you know, we normally quote around 12% or so for that group. So very impressive there. And if they were sensitive, if platinum sensitive, it was 69%. So, you know, median follow-up was 17.5 months. They had, I think the thing that struck me beyond that was really looking at the waterfall plot in this for those that were folate receptor alpha high. 97% of patients demonstrated a reduction in the tumor burden. So usually you see, you know, there's a few little buildings going up in the air and a lot of buildings going down. All the buildings virtually were going down. Very interesting. The spider plot, same thing, really impressive in terms of what they saw. Median PFS was 10.6 months for those that were folate receptor alpha high and 5.4 months for medium. So really some pretty astounding numbers. The AEs, GI and ocular again with the blurred vision and the keratopathy, which we most commonly see with this antibody drug conjugate, were the most frequent of the toxicities that were seen. Grade 3 events were hypertension, neutropenia, hypertension likely coming from the BEV. So this looks like a very, very interesting combination. And, you know, we'll get into a discussion, I think, of, you know, so how do you put this all in context as I think about really talking about the next paper. But, you know, what does this all mean in terms of, you know, how do you compare that to what's out there? And certainly the standard would be, and these were in later lines of therapy than what we saw in Aurelia, which is important, right? So even in Aurelia, they eclipsed those numbers that we would see in the platinum resistant setting. So that brings me to the next study.
Let me comment on this first, Tom, and then we'll go to the next one just to break it up. So what I'm excited about is, if I was to be so bold to make a prediction, the next approved medication in ovarian cancer possibly could be this mirvetuximab soravtansine.
Absolutely.
Yeah, absolutely. Right, Katie? So they have a
Absolutely.
single arm trial, Soraya, it's enrolled, and now we got to follow the responders for 6 months, which will happen very quickly. And then if we could get an accelerated approval, and again, it's outside the Aurelia label, it's where PARP inhibitors would not be used. So in a high unmet medical need,
it's already well enrolled.
There you go, right? Mirasol. So I'm hoping then that what you can take this data that you just presented, and if it gets approved, maybe, you know, get some reimbursement using both together and get the numbers you just talked about. Is that?
Yeah,
What should justify an NCCN listing? I mean, that's, can I be so bold as to say that? Like, I get it
No
approved.
question. High unmet
NCCN
need.
listed.
Yep.
Exactly where I was going with that. Exactly.
Absolutely.
Okay.
I mean, I would use this. I want to use this now instead of paclitaxel.
Exactly. Right. And so
Right.
That's what
I hope that we get there. And again, in the near, you're not biased, you're following the data. And because you've treated your patients with it.
Treated my patients on them.
It
works.
That's not a bias. That's yeah. Good. All right. So give us a few comments about your other abstract, Tom. Thanks.
Yeah, I mean, it's a smaller study, not quite the enthusiasm I had, but it's a triplet. It's a French study. It's a randomized phase 2 looking at Pembro. And Brad, you've certainly done a lot of checkpoint inhibitor work in the ovarian cancer space, which we can all share our thoughts on. In combination again with bevacizumab, almost ubiquitous now in these trials. Because you've taught us, Brad, how important it is in terms of bringing out the best in these other agents. And then combining that with pegylated liposomal doxorubicin, in this case with the triplet, they were using a dose of 30 milligrams per meter squared, which you might expect. So these were patients that were platinum resistant. So these were platinum resistant, which I always like trials that way a little bit better. I know you're not as big on, we talk about recurrent ovarian cancer in a lot of different ways now, because we look at molecular signature, we look at histology, we look at the number of lines of therapy, we look at whether they've had a PARP, we look at whether they've had BEV, all these different things fit into it. But I still can make sense out of if the cohort's all platinum resistant or all platinum sensitive. I have trouble when it gets mixed up and the numbers are relatively small, trying to figure out what's going on. But, you know, we do know the value of the BEV plus chemo from the Aurelia trial that I quoted. And I think that, you know, we have to keep in mind what the response rates were in that trial in terms of, you know, sort of the bar, if you will. So it was you know, I think that looking at this particular trial, it was somewhat complicated. They had a drug escalation phase and so forth, things that I don't think are all that important. They used the Pembro dose of 200 milligrams every 3 weeks. And primary endpoint was overall response per RECIST and the duration of response that they were looking at. They only had 22 patients. So again, I don't want to spend too much disproportionate time on this trial. They came to the conclusion that despite those patients, half the patients having grade 3 toxicity or more, that this was a viable regimen based on what they saw, that they had a 32% overall response rate in this, which of course is good for platinum-resistant ovarian cancer. They had a disease control rate of 53%. They're currently doing an expansion cohort of Pembro plus Bev. But again, you have to think about the Aurelia data in the context, you know, 27% response rate. and PFS of 6.7 months versus 3.4 months. So interesting combination. Katie, what do you think? I know we've exchanged some thoughts on this.
Yeah,
Yeah.
I think I was very excited about immune checkpoint inhibitors, and clearly as we said, I'm the USPI for first, and I hope desperately that it's positive. I honestly don't know that I'm excited about this. I think that it's not overwhelming to me. And as we know, in these small studies, the signal needs to be big to really justify a bigger study, or people that just like, not the response rate, but they just go on and like live forever. Like those are the two things that you kind of look for to really mobilize a regimen into a larger study. And this was nicely done. Congratulations to the authors, genuinely, but I don't think this is the next big thing.
Yeah, I think it's hard to make a case that the contribution effect of adding the Pembro is really seen in the results. And these data are virtually the same as what we saw in Aurelia. So I just don't see it. And with 22 patients, there's not enough there to break it down and try to figure it out any further. So
Right.
I'm not sure it warrants continued development. The Pembro Bev will be an interesting strategy. I predict that things may only get worse, but that's maybe that's because I'm the senior person here and I've seen too many of these negative trials.
Thank you, Tom, for that. Like very succinct. Leslie, I want to hear from you, and then we're going to close on hearing from Dr. Moore about Outback. But I want to hear from you, Leslie, about this KRAS low-grade serous story that's evolving. And there's an update of Milo, and we're studying it. Defactinib in the Veristem GOG 3052. Tell me about that sort of story, and then we'll hear about it.
Yeah, it's good to, it's great that we have this low-grade serous data. Rachel Grisham's doing a great job leading us here. And Brad, you're doing a great job. This is for Milo. So, Milo, I remember when we started this, gosh, I may have been a fellow still. I'm with you.
Long time.
But this was, very highly anticipated phase 3 study in low-grade serous carcinoma, second and third line chemotherapy, bemimetinib, MEK inhibitor versus physician's choice chemotherapy. And this pretty famously had no difference in progression-free survival, so sort of inconsistent with what we saw with trametinib in the GOG study. But clearly there was no difference here. So now this goes back and drills down on the biomarkers. And KRAS, given this is a low-grade serous population, 33% of the patients had KRAS mutation, 18% had other MAP kinase mutations like NRAS or BRAF. And the KRAS specifically, but both KRAS, non-KRAS MAP kinase mutations were predictive of response to bemimetinib in a big way. For KRAS, it was a 41% overall response rate versus a 13% if you were KRAS wild type. So, you almost want a do-over when you see this data and say, gosh, I wish we had known that when we had done the study, because, we started the study over 10 years ago and we just didn't know that at the time. But, we don't really get a do-over, but we get to learn from this data. And so now in GOG, Dr. Grisham is also leading GOG 3052, which is a study of a MEK inhibitor, VS6766. I guess I don't even know if this has a name yet. So anyone know it has a name yet? No name yet. Plus or minus defactinib, which is a FAK inhibitor, which we know has some activity in ovarian cancer from a long time ago. So we just really haven't developed that yet. So this is coming forward, and there's a portion of this randomized phase 2 study that will select by KRAS mutation. So in essence, we are getting an informed, do-over in a different sort of setting, but we're really excited about this trial.
And you probably saw that defactinib GOG study with their MEK inhibitor now has breakthrough designation.
Yes, it does. Thank you for mentioning.
So that's a big deal. Many of the times when we've gotten breakthrough designation, we've succeeded. As you know, we have all of us treat cervical cancer, but Iovance has breakthrough designation with their TIL therapy too. So Tom, are you sending next gen sequencing for KRAS in low grade serous tumors? Looking for it? You are.
I am.
Okay.
KRAS.
And
Yep.
Solumitinib is as NCCN recommended, I think, Katie Moore, is that right? So you can get it paid for?
It's, I thought it was trametinib.
Trametinib, sorry,
Trametinib.
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 Yeah, you can get it paid for. You can get paid for it in all comers,
For
but
any
certainly knowing,
low-grade serous,
yeah, knowing KRAS is helpful. And the one thing I just want to clarify, because that's true in this study, the 3052 is really, this is one of the things I'm most excited about right now on the planet, because it's not just a MEK inhibitor, it's a MEK-RAS.
Yeah,
MEK-RAF,
that's right.
because
Mhm.
it counters
MEK-RAF.
that, it counters one of the pathways that MEK inhibitors fail at in terms of, because MEK increases phospho-ERK, which is a resistance mechanism. So if you take
Right.
that out, you get that resistance mechanism, and it also upregulates FAC. So FAC does have single agent activity, but it's a brilliant combination. It's 3 drugs basically, or 3 targets in one package, hitting 2 resistance mechanisms. And they recently updated their data, and I'm not sure it's in the public domain, but it's no longer KRAS limited entirely. They're still collecting it because the responses are so good in everybody.
Breakthrough
Like, this is
designation.
the next big thing
It is.
Yeah.
Mhm.
for
And
low
it's-
grade. And those patients need, I mean, they are
need it.
young women,
That's
they
right.
live a long time, and we let's torture them with crap. This is going to work, I think. I'm excited about it.
All right, one cervical cancer abstract. So I was an NRG, or Gynecologic Oncology Group, cervical cancer chair for 11 years.
Yep.
And in 2009, we published in the Journal of Clinical Oncology, GOG204, establishing as the global standard platinum and taxane. And then we had this idea, because we were studying maintenance therapy at the time in ovarian cancer, that, well, why don't we just do maintenance therapy in cervical cancer? Sort of made sense to me. And then we love to work with our international groups. The Australians decided to collaborate with us. And since Australia is the outback, and since this was the outback sort of maintenance treatment, we called it the Outback Trial. And the USPI, which enrolled most of the patients, was Katie Moore. So Katie, tell us about this. It was in a plenary session. We haven't had a plenary session presentation. I don't
Since GOG 240.
I think
Since 240.
240.
That's right.
Yeah.
Tell us what went wrong or what went right.
Yeah.
with Outback.
This is a lot of lessons. So 900 patients accrued, about 460 in each arm. To remind the folks at home, they received cis-RT 5 doses of cisplatin, 5 weekly doses, with standard 4 field radiation therapy. It's an old trial, versus the same followed by 4 cycles of paclitaxel and carboplatin. About half the patients who were enrolled were node positive by imaging, and half were not. And otherwise, they were pretty standard kind of locally advanced, local regionally advanced cervical cancer. Sorry, I lost my words for a moment. And so the primary endpoint was overall survival, and we did not match it. We did not beat it. So what you saw was a 5-year overall survival. The event rate's so low now that we just had to do a landmark analysis. At 5 years, we're at 71 versus 72% overall survival with a hazard ratio of 0.9. Secondary analysis, progression-free survival, hazard ratio is 0.86. So at 5 years, 61% versus 63% remain progression-free. And so you ask what went right or wrong. So a few things we learned. One is that of the patients who were randomized to the additional chemo, 22% got 0 cycles. And not because they progressed, for the most part. It's really just tiring to get cis-RT and then ask someone to get more chemotherapy. And they just didn't. And so that's a pretty, it's almost a quarter of patients didn't get their assigned therapy, and an additional 10% didn't get the full therapy. So that's a little worrisome. Probably more worrisome to me was the fact that only 85% completed their assigned cis-RT in both arms. That was equivalent. So we had about 15% loss of patients completing assigned therapy. And as we all know, that's the most important part. If you don't finish cis-RT, your likelihood of treatment failure goes way up. And so those are issues that I think we've addressed in studies that have completed, such as your CALA study and the ongoing Merck study in this space, which is looking at immunotherapies as opposed to chemo. But I think those were big kind of problems in this population. Now, even if everyone had gotten perfect therapy, which I'd actually love to look at that data, I don't think it would have lifted the results, to be honest. I think we still would have not had an overall survival advantage. because I really don't know that extra chemo is the answer here, in my personal opinion. And so I am truthfully excited about the immunotherapy studies that are accruing. But this was 900 patients. We've learned a lot. We have a lot of tissue that hopefully with grants we can access and do translational work. And, you know, I think that it's a little bit, you argue with me, Brad, it's a little bit of a historical artifact at this point because it didn't use modern day radiation. And we still had a third of patients recurring. And that's just like every other study we've done, RTOG-001, you know, Peter Rose's work. It's been 30% recurrences for decades, and we're still here, but I don't know that we're still there with the type of radiation that we're using today. So I almost think this is going to be a little bit of a historical reference, but stop
doing it if you're doing it.
Yeah, don't do it anymore. In the
So
US,
Leslie,
no Warfield.
what are the other lessons learned in your mind, if you have any?
I mean, I think lessons learned are that, so we've had a couple examples of this where we've tried to do additional therapies post cis-RT that kind of changed from what patients were receiving during RT. Both of those, Tom knows what I'm talking about because he was the PI of that study. Both of those either didn't finish, couldn't accrue, or in this case were negative. So I think you have to sort of continue, kind of like a bevacizumab in ovarian cancer. Start it with radiation and then just kind of keep it going. So it's just always part of the treatment plan.
Yes.
It has to be well tolerated. And
Which
there has to be
Durva, Cala, and Pembro Keynote-18 are doing that.
Right.
It's better if you don't lose your hair. I mean, I think in this population that acceptability is really much more of an issue than it is in any other tumor type.
I agree with that. Yeah.
Other key points, Tom, in Outback.
Well, I think the main one is just stop it, like was said, and I do think that there's a treasure chest of translational data that's there that hopefully will inform us better trial designs. I do think the idea of randomizing with, where possible, is a better design with the cervix for a number of reasons.
So I would sort of put 4 buckets. Number 1, Katie, just as you said, dropout, right? Number 2, crossover. So if overall survival is the endpoint and every patient at recurrence gets the same treatment as the maintenance, then there's 100% crossover, which really is the third point, which now in all of these studies, Keynote 826, Beat CC, and Fermata, it's all PFS. And then also, Katie, number 4, as you said, you got to have the best treatment, and the best treatment, radiation was not used. And the best treatment, systemic therapy, whether it be bevacizumab or checkpoint, was not used. So dropout, crossover, PFS is the endpoint, and then you got to use the best treatment. And so those are good lessons. I hope they're not repeated. But I really appreciate you, Katie, and I hope this gets in a high impact journal. I hope that people see it for what it is, and that they put it maybe even in the New England Journal. It was, as I said, at a plenary presentation at ASCO, so that we can read it and learn it and grow from it. So
Agree. Work on it.
Yeah. So Tom, I'm going to give you the last word. Appreciate your contribution here, and then we'll wrap it up.
Well, I just think that it's interesting to me that we've had so much impactful data that's come out at recent international congresses, and this last one was a little bit underwhelming, frankly, considering what we've seen in terms of changing the field and changing the standard of care in a number of disease sites. And so we need to continue to keep working and realize that not all these are going to turn out to be game changers. But it's sort of like baseball or anything else. If you don't play the game, you really don't know who's going to win. And even though you can make a lot of predictions, I think I was surprised a bit by Outback, and I was surprised a bit by Boost, for example.
Right.
Those would have been both blockbusters, because those would have changed what we do. I do think there's small wins here. There's some of the early data and some of the compounds that we have that are in the pipeline look very promising, and I do think that we'll see some real quick approvals in the next months to very short years. We'll also see such things as the mirvetuximab Bev data that I think will get compendium listing based on the strength of that data. So I do think there are some wins that we've seen, but we just need to continue to enroll patients on clinical trials is really the bottom line, because without that, we could sit around and talk. In fact, our opinions would be even much stronger without any data. But the data really helps keep us all on the right lane. So I'm glad to do that. So please keep us in the right lane by enrolling your patients on clinical trials.
And I want to thank Jenna Cummins, who is one of our senior leaders within GOG Partners, who made this happen. And you will see now, you will see GOG Partners highlight reel. Every time there is a major oncology meeting, you will see likely others, but we want to brand this and you will see it, and stay tuned. And so long for now, and thank you for our participants, and we appreciate your attention. Bye.